The Dunning classification is specifically used to grade iatrogenic aortocoronary dissection, a rare but severe complication that occurs when an intimal tear during percutaneous coronary intervention or diagnostic angiography extends from the coronary artery retrogradely into the aortic root. It is specific to catheter-induced injuries and should not be confused with the Stanford or DeBakey classifications, which are used to evaluate spontaneous aortic dissections. The classification divides aortocoronary dissections into three classes based on the extent of retrograde aortic involvement. Class 1, the dissection is limited to the corresponding sinus of Valsalva, the ipsilateral aortic cusp. Class 2, the dissection extends into the ascending aorta, but the extension is less than 40 mm. Class 3, the dissection extends into the ascending aorta for greater than 40 mm. While the classification does not perfectly predict clinical manifestations, it provides a standard framework for determining whether to manage the complication percutaneously or surgically. Class 1 and 2 generally managed conservatively via percutaneous intervention. The standard approach is to rapidly deploy a stent at the coronary ostium to seal the entry point of the tear, thereby halting propagation of the false lumen. Class 3, typically an indication for emergent surgical repair, as the extensive propagation carries a high risk of catastrophic aortic rupture, tamponade, or extension into the arch. However, in highly selected hemodynamically stable cases, conservative medical management with strict blood pressure control and close tomographic follow-up has occasionally been utilized. The original diagnostic criteria and classification system established in 2000. The research paper is titled Iatrogenic Coronary Artery Dissections Extending into and Involving the Aortic Root and was published in Catheterization and Cardiovascular Interventions, and this is the reference. Recent literature and clinical reviews. A July 2026 literature review published in MDPI titled Morphology Matters discusses utilizing computer tomography or transesophageal echocardiography to establish the most accurate classification during or immediately after a procedure. A recent case report documents a patient who suffered a class 3 dissection following percutaneous coronary intervention for a chronic total occlusion, demonstrating that even severe classifications can occasionally be managed medically instead of surgically. A January 2026 paper explores the use of intravascular ultrasound guidance to precisely manage a dissection, reinforcing that class 1 indicates limited dissection while class 3 reflects severe aortic involvement.